talk a little bit about creating a toolkit. And again, hitting the highlights here. Our plan is to actually have a all-day training in crisis in the fall if we can. And so we would go into more depth, and also um, when you do your survey at the end in terms of giving feedback, you could also indicate additional areas that you think you might need for support. So you've heard me talk about this kind of all the way through. I'm going to talk largely about two main types of cool toolkits. One is just tools to think about the visuals and the different supports you can have. And the best way I have found to develop these toolkits is to really get, again, together with teams. So we use our child life teams. We've used speech pathologists, our psychologists, behavioral support folks, experts in this area, and people who have these materials, and really develop standardized types of schedules and things that we would need that are specific to kind of a subset of this population that will work with most patients. And we do have some supports that we can use. I'm going to go through a little bit, but then we have them adapted for bigger icons, smaller icons. We've made a subset in Spanish, but we've made some subsets along the way, and then we've made them for specialty kinds of care. But we've worked with different clinics who need them frequently to develop one specific to their clinic. But once you've developed these kind of standardized things, you can actually create them in a way that it's easy to print them, to laminate them, to get them Velcroed and get them up and running. And then what happens over time is staff get really familiar because they're the same types of systems and they work pretty well. And then there's some additional tools that you can kind of add for items that can be available that are really helpful. Then the other piece I'm going to talk about is just behavioral personal protective equipment for the crisis piece, and thinking about how to infiltrate that throughout your system with some tools that you can use to identify what you need. And then some kind of I put this as me sheet on here, but some kind of a sheet or tool that you can hand to parents that they can fill out that gives you just this solid information that you need about these patients. And then you can potentially put that in your system. So initially, when you don't have an EMR set up to handle that, it could be that somebody puts it into a clinical note. That it could be that you just scan it in and that you can find it when needed because it's scanned in on that patient as an extra material until you can build additional systems, et cetera. But just thinking about how do you put all these things together so that teams can start to use them as you develop your system. So some standardized schedules that we create across our system are these blue, we use these blue folders. We typically use blue, partially because Children's Hospital is mostly blue, but you can use any types of things. And these actually wipe off and clean well. They're plastic folders, and inside there are laminated pages with more icons. And we use icons in each area that are specific to the things we typically use. So we have a standard set for any hospital admission. We have a standard set for our emergency room. We have a standard set for our inpatient psychiatric unit. We have a standard set for many of our outpatient clinics, but these are portable. They have many things in them. They all have standard weight cards in them. And these are just a subset of tools that we can easily deploy across our hospital and can access in different locations. And we have them around. So in the emergency room, they're just, after use, they are cleaned, wiped down, and anything that's ruined is thrown out, and then they are put back. And so when they need one, they can just grab it. And then somebody checks them periodically to make sure they have the standard set of icons in them. And there are some backups to pull for things that we lose most frequently. And then we have a laminated written schedule that they can, again, just wipe off and use dry erase markers on for patients who are reading, who need a simple schedule. And again, these are laminated pieces of paper. We do have some dry erase boards, but we have occasionally been hit with them. So sometimes the laminated piece of paper just works better. They're cheap and easy to replace. And so we just have a whole subset of these. You can pull it out with us, a little box of pens, and you can use a written schedule for our readers. And these are easy ways to just adapt care that can be easily kept across our hospital. The biggest part is making them. And I will tell you, when we have hospital employees on light duty who need things to do to be on light duty work at the hospital, they are often deployed to us to work on our visual systems. And that's one of the ways we maintain them, is by giving our staff who are on light duty something to do. We have a whole systematic way to train them, and they can just work on those and pump out a whole bunch of set of new schedules. And one day of light duty can catch us up with what we need for the next 3 months. So that's how we kind of sustain ours. We also have a whole subset of social stories. We continue to create new ones as we need for patients, but we have a subset that are already created and we can do little modifications to individualize. They're all electronically stored. We have a subset in a tub that, they're laminated and can go out deployed, but sometimes we just print these out and we'll take them to an individual child. They can take them home. We send them electronically to parents. And we store them anytime somebody creates one, it's stored in a shared area so that we just always have, we hardly ever have to create from scratch anymore. We had to create new ones around COVID. This one, COVID-19 vaccine, we didn't create. This is one that the CDC put out, I think. But, and they can be individual pages or they can be a page like this. We typically do individual ones, but we have them for all sorts of preparation. And again, our intake team and our child life teams often send these out to families for prep work. And we sent a ton of them out for COVID to prepare for the both the swabs and the vaccines this last year. But we send them out for all different procedures. EEG is another common one that we're preparing kids for, that we're trying to just do a little desensitization before they come in so they're not worried. But we'll do these in our inpatient units. We send them out to families for outpatient clinics. We have them in the ED. If they're going to have to do something, we'll print or run them down a book to do some prep work prior to procedures that are scary for kids. We have a subset of choice boards. One thing we find is that kids don't know what's available at the hospital, right? So even if they're pretty good communicators, they don't know what we have. And so sometimes all that language around the choice is confusing if they're stressed or anxious and they break down. So we have found if we develop a subset of choice boards that we can put in, or a picture exchange book that we can put in the room with the things that we have available, it really helps them just kind of know what those options are. And some kids, can't eat here while they're here. Sometimes they don't have their regular snacks, but we do have snacks. So it's helpful for them to kind of just know what we have. So instead of saying no all the time, we're saying, hey, I don't have that, but these are what we do have. And it's just a really easy way to do behavior management. We find if we've enhanced their communication, things go so much better. So in your different clinics or in your different units that work with the kids in different ways, if they're not able to eat during portions of their stay, it's really helpful that they know what they can choose that are not food. Or if they're on clear diet because they're getting a clean out, it's important to know, gee, we have 3 kinds of popsicles, this kinds of Jello. You can have, Sprite and Gatorade or, whatever it is that they can have. And when they see all the things they can have, that often quells the challenges for what they can't have. So making sure those are available. So those are just a couple examples. We also have timers and all sorts of additional things from the lists above in the other presentations. So when you want to think of a toolkit, this is a kind of a weird way to think of it as a toolkit, but preparing your workforce for high-risk behavior. You really have to think in terms of formal training. Consider a standardized assessment, and that is for the person who's coming in. You have to know what the risk is, right? If you don't know what your risks are with this specific patient, then your staff are going to figure that out often the hard way by tripping upon the risk. So it's really better if you develop a standardized assessment that helps you understand kind of what are the typical behaviors this child may present with. The environment from entry to exit, which hopefully can be part of this whole package approach to crisis management. And then thinking about behavioral personal protective equipment. So hospitals, we're great at protective equipment. We're great at thinking about, do we need gowns and gloves and masks and all those things? But there's a whole subset of behavioral PPE that we can also use to help our staff who are working with patients who might become aggressive. And you have to think about, what do you need, but also where do you store it? How do you clean it? How do you get it deployed to your different places? How do you know what you need to use? And often if your staff need to wear equipment, you need to think about your parents too. So we have parents who come in just absolutely bruised and battered. We definitely let them wear our equipment that we use. If we have a lot of parents who are like, can I have some of that? Yes, you may. But we won't send our big things home. So I'll give parents a pair of Kevlar sleeves or gloves to take home and then tell them where they can get their own. But if they're wearing a helmet, because we're having to wear a helmet while working with an individual, we won't send those home. We'll just give them the resources for how to access. There is an evidence-based assessment for determining behavioral PPE. It's called Initial Behavior Assessment, and there are a couple articles about it as well. The actual assessment was created at Cincinnati Children's, and it's free, and we can give that out. It's just a PDF, but it has been evidence-based, and it's a structured interview, and it really just goes through the forms and frequencies of problem behavior, how intense it is. It gets the areas targeted, and then there's an algorithm to determine the kind of personal protective equipment that would be recommended, and whether it should be worn by the staff at all times or if it should be just in the room or kind of close by. And we use a version of this in our this version is actually used in our inpatient psychiatry unit for our developmental disabilities, and then we have the ability to use it throughout ambulatory, and in our inpatient, we actually combine this assessment with another one for determining risk and interventions. So we use this across our system and find it extremely helpful. When thinking about physical management training, it's important for probably hospital-wide to have some kind of a de-escalation training, but there should be a subset of people who are also trained in safe physical management. Because we do get in these situations where we need to physically intervene with patients to keep them safe and to keep us safe. And it is important that we know how to do that without causing injury. And so this is not an end-all be-all list, but I just throw a bunch out there because there's more than one way to do this kind of training. These all offer something a little bit different. There's a bunch out there, and I would encourage you to look at what works for your system. There's also now pretty recently out this quality improvement article that talked about how they went about determining the right program for their hospital. I believe this was done in Colorado. And so it was just such a really nice walkthrough of how they looked at the different systems that I include this for you and encourage you to get this article and just look through it if you're thinking about adding a formal training to your workforce. And then I put this up here because this one is specific to autism. And again, it's not going to work for every hospital, but it is getting rave reviews. And so I would encourage folks to consider this as the Marcus Autism programs. It was homegrown at Marcus with people who do behavioral intervention for a living. And I'm hearing a lot of people using it as kind of a newer one. So it's just getting out there as being a really effective quality training it is for autism, but it's also for other developmental disabilities. And I believe it would be very appropriate for any behavioral health population. We have a listing that we started long ago on what we call universal precautions for safety. And this is one of the ways that we got information out to our staff, and that it's put out in an annual training as part of what we call our safety college. But we put some quick tips out that we put out to staff to just kind of be aware. So making sure, when you're dealing with a patient who has behavioral risk, that you're thinking about the clothing you wear, right? So covering your arms is super helpful to your safety. Making sure your long hair is not, hanging here in front of your face. Hair pulling is a really common thing when a child is very upset or an individual is upset, and especially when we're doing care and kind of in their core. Making sure people close are covering their toes because they get stepped on, that we're not wearing jewelry, dangling earrings, etc. I've seen those get pulled completely out and ripped earlobes. I've seen those. I have not had those myself, and I hardly ever wear an earring anymore because of some of the things I've seen. Again, we got rid of all of our lanyards. Preparing the environment, which I went through. I'm certainly not going to talk about that again. Our universal precautions include reminders about safe positioning. So we teach this specifically. It's taught in our physical management, but we also, as a team, are constantly working on any procedure to call a timeout and say, let's get in good position and make sure everybody takes a proper position and we've got all limbs covered before we do any invasive procedure. Helping our medical teams not get backed into a corner, that they always have a path out of a room, reminding people not to turn their back on an agitated patient, kind of a thing. We try to use those side stances. So we're never trying to use a show of force or some kind of like overwhelming, powerful response to somebody who's agitated. that doesn't usually work with our folks with autism. And so it's not effective, it's not respectful. So really, if we can give time and space, we will back up and change our, proximity when we can. But if we need to get in there to keep them safe when we're blocking, we need to know how to be in there in a safe way. So I'll often working from the side or a little bit behind when we're blocking, trying not to be right in front of them face to face, and turning our body to the side, so that we can move away more quickly and they have less of us to kind of get a hold of. It's much less threatening. And then when we want our staff to wear the right kind of personal protective equipment, and again, we use that algorithm to do that. But I'm going to walk you through some different kinds to do it. We like to put on equipment prior to interactions if we can, but sometimes we have it in the room and we'll put it on as needed. But I will tell you, it can look like we're coming in like the cavalry sometimes if a child starts to get upset and we start to put all this equipment on. So it kind of looks like almost punishment. And so we have to be really careful in terms of how we do that when we're working with kids. So oftentimes we like to have equipment on prior to something occurring if there's the risk present. So we use Kevlar sleeves and cut resistant gloves. I'm not going to walk through every aspect of this slide. You can read these, but these are for cut resistance. They do not prevent you from any injury, but they certainly reduce the severity of injury. So if you get bit with Kevlar sleeves on, you can still get a whopping bruise, but you are so much less likely to have your skin break. But you still need to learn how to do a bite release, because if you're pulling your arm out of a bite, you're still going to get more injury than you do if you feed the bite and know how to get a release done. Okay. These can typically be washed in the washing machine, and we've worked across our organization to know what can throw in with the linens, and it just goes through and comes back to us in the big linen watch. And then we have specialty equipment that stays on site because we'd lose it if it went off, and then is laundered per infection control procedures or wiped down appropriately. Okay. We use padded arm pads. And so our bedside staff who are assigned to our patients to work like a patient attendant, we have what we call behavioral health specialists, and they are like a psych tech. They have some bachelor's degree and some experience, and then we do training. And they are only assigned to our patients with significant risk. And we have them wear Kevlar sleeves and gloves and arm pads as a part of their equipment. They just wear that as like part of their uniform. So it doesn't matter which patient's risk they're with, they're going to wear at least that level because they're only assigned to patients with behavioral risk. And so this just helps them when things go awry. But that padding for the forearms helps, when they're blocking themselves against an aggression, and it's most likely to prevent them from getting bruising. And for somebody who bites, it's additional protection against that with the Kevlar. Again, these also go machine washed. The impact cushions, I can't recommend impact cushions enough. They are a 2x2 blocking pad that has handles on the back. And they're so great for that quick self-injury when somebody's head banging or banging against the rails, and we can put it between them. We never use it as a shield because you're more likely to push a patient with them. So we just won't let staff pull them up as a shield. But we do, and we don't want to put the arm through the straps because they could get pulled and injure a wrist. But they're so great for blocking that self-injury. And we have these, we have different units that have them, and we have them across the hospital. And again, as we build this new tower, we're looking at where we're putting them as well so that we have these quick and easy to grab. But every unit actually has an impact cushion, at least one on their unit with a safety bag. So we've put them across everywhere we go because they're so easy to and portable and easy to use. Our staff love them. The normal medical equipment that we think about for behavior, but when we have kids that spit, I more frequently than I'd like, get called and asked if we can put spit masks on kids or spit hoods on patients who are spitting a lot. And my typical answer is no, because we don't know the trauma or all the different things that they might be going through. And sometimes kids have medical trauma, and if we're starting to put things over their head, and we don't always know what the different things are, it can really create more trauma. So we protect ourselves. So we use the shields, the masks with the shields to cover our own face to help protect us against spit. If they're significantly spitting, we will wear gowns and gloves, etc. When we're doing this care to make sure that we're protecting ourselves from their spit, but not causing additional trauma to the patient. We do have hats and hair covers. So we won't let our staff wear like their cruddy ball cap from home, but we do have them available here. They can buy a children's hospital hat, or sometimes we've bought small teams, logo hats, so that they can have them just hanging on their desk and we can use them as needed. And they just keep their own individual one for patients who hit, but we also just use the different surgical caps for a patient who might pull hair. And what that basically gives us is one more second or attempt. They get that first, and then it gives us time to get our proximity out. So we're not likely to get our hair pulled as much when we do that. They'll also sometimes wear bandanas in addition to the hats to cover their hair. We have that wonderful sewing room we have, which is one of the best resources ever, but we have them take just our normal children's hospital scrub tops and cut them down the seams and then put snaps in to create breakaway scrubs. And then we'll put these on kids who do a lot of grabbing of clothing, and the staff will wear them. And so the kid grabs the scrub and it just pulls right off, and we're still right there working through the behavior. And it allows our staff not to get caught up into a big grab when they do that. So we use these for some of our kids. We've done the same thing with net Kevlar. So kids who grab at the neck or grab at shirt lines, we will use Kevlar. The problem with net Kevlar is that if you don't sew the snaps in it, it really becomes something that you're struggling with somebody having a hold of you around the neck. So the only way we will put net Kevlar out on the floor is if we've modified them and put the snaps in to help them be breakaway so that they can't strangle a staff with them. We use all sorts of kinds of chest protectors. This is just one example. And again, it's that padding chest for the abdomen. So kids who are kicking when we're in there doing close care and work, or do a lot of bodily hitting, or are really big and can hit hard, we just provide these to our staff. They're also used for kids who grab at breasts. So we do have a subset of kids who know they can get a pretty big reaction by grabbing the breasts of women who are working with them. And so the chest protector makes that really hard to do. And then helmets with face shields. We have a variety of these in different sizes that we keep around. These are not for patient use. These are only for staff use. And we will use these. We often prop them up on the top of our head when things are going well, and then we can just drop them down when we're having to get in there for kids who will really target heads or come at us pretty extremely. And again, not everybody needs PPE at this level. We are a large hospital that serves a very high risk population, and we want to keep doing it. And we have found that these reduce concussion so significantly and allow our staff to stay in there. It is hard when we have staff walking around with equipment on, and we will take, if the child needs to walk out in the hall and take walks and things, our staff will wear this out in our hallways with the patient. And we do try to do those walks where there's less traffic and less kind of sight. But I think it's kind of become, we don't have a lot of trouble with people complaining about it or whatever. I think at first it was kind of a big challenge, but most of our staff now know how to explain it to families who may ask. And it's to say, we treat everybody here, and we want to treat everybody and help them get the medical care, but sometimes we need to keep our staff safe when we're working with a patient who struggles with their care. And so it's really just talking about that rather than talking about that patient's behavior or anything, and just saying we're just trying to keep everybody safe while anybody can get care here and do it safely. And that works really well overall. And then these BitePRO, these are Kevlar, and you can get padded and unpadded, but they actually go up across the back of the arm, because if you've worn Kevlar at all, what you'll often know is that kids will actually pinch you above the Kevlar on the back of your arms. They're really good at getting that fat on the back of your arms that bruises really easily. And so these actually take care of that with the ability to just cover the whole back of the arm. I don't like the padded ones as much just because they're so bulky to wear. And these come from like the UK. They take like a month when we order them, but they really have added that extra layer of protection to the upper arm for folks who bite or pinch commonly in that upper area. So those are kind of the big things we use for our toolkit for aggression that again are the high level equipment, the helmet, chest protectors, the BitePROs, the Kevlar and the scrub tops, or the neck Kevlar and scrub tops, are typically specialty equipment that is really, if they're typically only deployed by our internal behavior safety team, because if you have that level of risk to need that level, you need a whole consult team that's working on you. Our hat and hair coverings, our masks and gowns, our impact cushions are on the floor, everybody's floor, and then the arm pads and Kevlar are pretty much more commonly available. The arm pads are mostly with, again, those bedside staff, but the nurses can easily get them if they need them as well. And again, if the nurses need to wear that level of equipment, we're typically on them as well. But so some of this is infiltrated across the hospital. We have Kevlar sleeves and gloves in every PPE cabinet across our entire system, inpatient, outpatient, everywhere. So we call that the same thing as like where you're going to do your chemical spill kits and your additional just regular PPE. We have put Kevlar sleeves and gloves across the hospital. And then the unit, any clinic or unit can order more. So we do have some other additional places who have ordered additional beyond their required set, which is like there's a PAR number. I can't remember what the PAR is. It's like, I think it's 5 sets probably in each kit. But what that means is basically no matter what, when a patient comes in, if they have some risk and they want them, they're available everywhere across the hospital. So again, looking at it as a systems level. So where do you need the resource? Who deploys it? How do we regather it? I just had a hospital call me the other day that it's put the impact cushions out and found excellent use with them, but parents are taking them home. And so, that there's a lot of things you have to think about, like when patients go to discharge, how do you get the equipment back? When, typically if there's an impact cushion in the room, we almost always have a staff in the room too. So that the staff are part of that, knowing that when a patient discharges, part of their job is to gather all of our materials back and bring them down to us. So we work with that staffing team to know that that's part of their job when they work with behavioral risk patients. But yeah, that's expensive. They're just under $50 a pop. So you certainly don't want too many of those walking out of your building. But the thing is, parents love them too. And we definitely give I have a whole resource list, and I will hand to parents if they're interested in getting them, so they know at least where to buy them. And then we can talk to them and talk to their, whether they have a waiver or, kind of what their funding options are if they need support with their different teams to keep everybody safe.
Thanks, Dr. Sorensen. That was great. And there are a ton of questions, so I'm glad we have a little bit of time. So just going off of what you were just talking about, one of the questions had to do with if you could share what staff members make up your behavior safety team.
Sure.
You've made a lot of amazing impacts at your hospital. Thank you for sharing.
Yes. So the behavior safety team, what I first want to share is it was a development over time, 10 years to where we are now. It started with me and as a consultant who was available part-time. And basically when a child came through who needed that level of work, the first thing we did was develop a referral system. Everybody was screened upon admission, and when they had the risk, they were referred. And I'd go do a quick assessment and give recommendations and then continue to consult on that patient as needed. Where we are now and where we've evolved over 10 years, I always say build it and they will come. But what has happened is we have a 24/7 team now. So we have bachelor's prepared staff. We have 2 per shift of bachelor, and there's actually 14 of them, but they don't all work full time. So there's 2 per shift, occasionally 3. And if there's 3, we have somebody who does what we call a mid shift, and that just helps us clear our gaps in the middle of the Monday through Friday kind of work day. But their title is a behavioral health facilitator. and they have a bachelor's degree plus experience in working with this population. We get a lot of them off of our either psychiatric unit, especially our developmental disability, or they are homegrown in our medical center because they've been the bedside staff. And my behavior safety team does not own our bedside staff. They are managed by another portion, but we work with them intricately. And they are behavioral health specialists who, again, bachelor's prepared, who have training. We give specialized training to work with this population. They come in knowing they're going to work with kids who have behavioral risk. We like them to have some experience, and even if they don't have any, then you have to want it and you have to be willing to work with this population. And then we have our patient care attendants who do not require a bachelor's degree. And they will work with this population as well. We give them very similar training, but our highest risk patients are matched with our top competency staff who are bachelor's prepared with this extra training. So then my team, we have behavioral health facilitators. So basically they're a step above the behavioral health specialist just because of experience, maybe same degree experience. We do get a lot of folks who are working on nursing degrees or nurse practitioner degrees or, masters in counseling, masters in social work, et cetera. And they do this as kind of the experience leg. And then we have some what I'd call career folks. But this team, 2 per shift, they round on the patients at least twice a shift. They're helping with procedures as needed to the units. They're consulting. They are part of our behavior response team, which is our crisis team. We have 2 levels of crisis. One is called a huddle we think escalation is going to occur and we need more mitigation to prevent. And then and then we have the actual code response, but those response teams are made up of doctors and nurses and our behavioral staff. So it's a whole crew. And then they do our intakes and our risk assessments, and they're basically prioritizing and working this whole safety systems for acuity throughout the entire admission of this patient. And then we have a behavior health consultant, which is a master's level person that might have a BCBA or behavioral training, who's helping with our more significant behavior planning. And then me as a psychologist, we have a program manager and a director who also directs many other things, but just oversees us. And then we have an intake team. So we have an intake coordinator and 2 child life specialists. One is part-time. And what they do is help their liaisons to other child life specialists. And then they manage all of our pre-work, prep work, and moving kids kind of through our system from the intake side or helping us designate support through ambulatory. So it's a huge kind of group, but we're under 20 people who man a system 24/7.
That's great. And I think, you just kind of touched on the child life specialists. One of the questions was directly related to this. Do your child life specialists ever wear the protective equipment, the behavioral protective equipment, or are these typically brought out once child life interventions have failed or haven't worked successfully in a particular situation?
That's a great question. So most of our child life staff don't have to wear too much equipment. When they do, it's usually the Kevlar sleeves and occasionally gloves and the arm pads. We're not usually putting them in the huge helmets and the larger things, although I can't say never. The 2 child life specialists that work with us have really intense behavioral training and also physical management, their training, restraint, et cetera. We do try to actually keep them out of that and keep them pretty clear towards the psychosocial side of the interventions. So they don't usually have to do that, but they are very much trained in the case that we're in the event, because they do a lot of our step down from patients who don't quite need our higher level support, and we're trying to move them back towards child life, but they're kind of our first level to move them back to, because they have that higher training where we're trying to peel off that equipment and peel off some of the stuff because they're doing pretty good and stabilizing. So most of this equipment comes in when other child life interventions have either not worked or we think it's beyond that. But we also try to stay really integrated in child life and have them still come in and normalize that hospital experience like anybody else would, as long as it's safe. But we just grade that based on kind of the safety and Sometimes it's more with the staff, just offering them additional items or problem solving with them, some additional engagement things. But if we can, we get them right working with a child, but not in that level of equipment.
That's great.
Mm.
You know, I think the key to everything that you're mentioning just has to do with that clear communication between different departments and staff and kind of that ongoing, you know, I think, you know, I think you had talked about building a culture and system. And I think that's really the key, right? The culture around understanding how to address these different challenges and who would be the best person and what resources are available. So I think that speaks volumes to creating that culture. Another question had to do with, you know, you had mentioned several safety programs that are available, and depending on each setting, there might be one or another that's utilized. You talked to, specifically about the newest one from Marcus Autism Center. So there's a question regarding the MAND program. Are you familiar with it? So this person mentioned that their hospital adopted the MAND program for managing patients in crisis. Do you think this is appropriate for patients with autism spectrum disorder, or would you recommend an additional program that is specific to ASD?
I don't know if I can completely answer it because I'm not trained in MANT, but I know other hospitals who have used that and do some pretty nice work around autism. But again, I think it's really just about having the expertise to make sure that they mesh. So even in our hospital, we use TCI, therapeutic crisis intervention, and we've used CPI. But what we found is our inpatient psychiatric units use TCI, and we have so many patients who go back and forth and staff often running back and forth that we really needed everybody trained in the same way when it came to truly a crisis, if we had to restrain somebody or do something. Um, so we decided to go with one set of training, and TCI is not what I would choose for autism. However, we have worked in other ways to make sure folks are have additional tools in their toolbox for autism that are well outside of TCI. And what happens with TCI then is the de-escalation is fine, especially for a verbal person. But you know, we can then be on the same page if we have to use physical management. We can work together to do it safely. And so that was the most important out of those kinds of systems. I think severe behavior in autism will trump any system that you have to have additional expertise because it's just so hard. And so I think I just rely on those systems to more teach us how to be safe when we have to physically intervene. They still aren't great at telling you exactly when, right? We still have people, we probably block and redirect a lot longer in autism than TCI might suggest you need to. But it's about that expertise of knowing how to work a patient through their behavior, and that restraint isn't going to teach them anything. It's truly just safety. So I don't have an exact answer, but I would say always look beyond.
Right. There was another question that had to do a little bit with kind of more the infection control side of things, right? And you touched upon it a little bit in terms of how you deal with washing the personal protective equipment. Some of it goes, you know, with linens and is returned to you. Other things you guys wipe down. This one was a little bit more specific to some of the things that are in your toolkit, like the use of Velcro. And you know, how does that come into play? Like, how do you troubleshoot with infection control policies the use of Velcro, and how do you clean Velcro between patients?
Great. So COVID actually made this really, really hard. And we had to go to single use with a lot of things. They are starting to lighten us up a little bit, but even if we took wood puzzles in, we used to wipe those down and clean them between patients, and they basically said wood puzzles are one use, one patient. So we've actually gone through a lot of resource more with COVID. Prior to that, even the Velcro, we were pretty much able to wipe everything down before. But if we had a patient with significant like contact precautions, then we were more likely to send those visuals just home with the patient. You can take
Right.
that with you. So anything significant for contact precautions. But if they weren't on significant contact precautions, just like in ambulatory, that we were able to wipe and clean and reuse. But if yeah, or if they had any kind of soiling of the material that would penetrate that Velcro, then we, we would get rid of those. So, or again, let the families take them home if they wanted them. Sometimes we send the visuals home with families anyway if they found them really useful. I didn't seek any approval to do that. I just do that because it's the right thing to do clinically. And we have, we continue to make these, and we don't try to send, like, if you've taken a visual schedule home, we don't necessarily send you with a second one if you didn't bring yours back in, like if you're a frequent patient, but you typically get one. But we're pretty generous with the materials because we want this patient to be better in every way. And if they're better when they're at home, they're better when they come back to us.
Absolutely. And I think that that speaks a little bit to trying to find some of those additional funds, right? Or
Mhm.
pulling in some of those
Right,
volunteer
right.
resources and in terms of people or
Mhm.
others who might be willing to help out a bit so that, obviously all these things end up, Velcro is not cheap.
It is not.
So it's one of those things that can add up pretty quickly. So um, another great question just came in, and this is something that I know that I've dealt with for many years at the hospital, um, that had to do with, your security staff and the use of security staff.
Mhm.
Um, we've had many situations where security has been called by others,
Mhm.
and it hasn't been helpful at all because they're not trained,
Mhm.
and they've created more challenges. So the question here is, do you use any security staff to help out alongside the medical staff from time to time? If so, how did that work? We have armed security. How well do you think that fits in when working with children that are behavioral and autism patients?
Yeah. So yes, we use security at times, and it's been again another evolution, right, over time. So early on, I would uh, provide trainings to our protective services group. So our leaders, protective services leaders, were always willing to like try to figure out how to work well together. So again, it was started with the leadership. It starts with the culture change. It starts with how do we, and we really established kind of what's clinical and then what do we need protective services to do. And so typically what and really heard from them what situations they got pulled into, right? So sometimes people would have this outburst, a patient having an outburst, and they'd call protective services and they're like, we want you to go in there and restrain them. And that's, for me, I was like, oh, and oftentimes the person's sitting there just fine when everybody left the room, right? So there's no need to go in there and restrain them. But so we did a lot of discussion, even to helping protective services like know how to even coach a clinical team, so that because they didn't want to be used that way. So like helping them work together. And then now all of our protective services are also trained in TCI. So we're all trained in the same physical management, which also helps us when we do have to work together, how we do it. But we really tried to separate, is this clinical or is this true safety? And then we do, we serve a whole behavioral health population that's also can have criminal backgrounds and be on parole and have all sorts of things too. And so um, how we use them in those situations is actually similar, but a little bit different, right? So our goal in a pediatric facility is never a show of force or this kind of like use of, police to do anything, but they are a separate set of hands. So in crisis, we tried to establish like when we need to take a patient from downstairs to upstairs, we need you to man the elevator and get everybody out of our way, So we really use them as that support role. But when we have a person who's 6'4", even if they have autism and we need extra hands, we invite them to come help us, but we also try to tell them exactly what is needed. But that's been an evolution, and it's taken some time, and it really takes that communication and teaming and collaboration and talking about their perspective and ours. And we definitely have some who have been more, who've kind of jumped in, more quickly, and that we haven't felt helpful, but we try to debrief after any time we work together to talk about, like, this patient has autism, or they really don't, and I will speak up in a crisis and say, hey, they're nonverbal. Stop talking. Or, we're gonna have one communicator, and we just, we will communicate them through real quietly and carefully. But it really takes a building of that relationship to do it. But we have found that they really appreciate, our protective services really appreciate the collaboration, because they don't
Yeah.
want to go hands-on in a hospital. Um, and they love planning, like when we have to go in to, if we do have to do a restraint, we need extra help. They love it when we plan and talk about and let us do the talking, and we all know how to kind of apply the intervention.
Yeah, I think it's crucial, just the act of communication. I think one of the biggest challenges we faced, and I know it's a big challenge even today, is the continuous, just turnover from the security folks. And so we would train a whole set of staff. We used safety care at the hospital, so that program, and we would train all of them. And then, 1 month later, we had a whole new set of staff. And so keeping up with that could sometimes be a little bit challenging, and we didn't have a Dr. Sorensen at the helm to really facilitate, all of these systems. So I think it's fantastic what you guys have set up, and I know there's lots of comments about that how it just seems like the system that's been set up is really benefiting all patients and staff, and keeping everyone safe and a positive environment. One question that had come up before, and since we have a little bit of time, I'm just going to bring it up now. This came in before. I would love to hear any of the specific movement suggestions you have for patients that may be in isolation or limited to their room for the majority of their stay. As a child life specialist, I'm often brainstorming new ideas or supports for patients with autism or behavioral health needs. And I think it's a great question, right? When you have that limitation.
I'm going to have you ask that one more time because my doorbell just rang, which I'm ignoring.
Okay. I will ask it again. The question is, I would love to hear any of the specific movement suggestions you have for patients that may be in isolation or limited to their room for the majority of their stay. As a child life specialist, I am often brainstorming new ideas or supports for patients with autism or behavioral health needs.
Yeah, that's a great question. So we've had to be creative again. So sometimes it is try to find that bigger room and giving them more space with mats on the floor, things to do on the floor, therapy ball, bring in a therapy ball and get them some ability to move differently. When we've tried to get them out, again, it depends on the infection, but we will work with our infection control team, call them specifically, talk to them about our risks and the different things. And we're often we have a back hallway, and we can often get them out in that back hallway, especially after business hours. It's almost completely deserted after business hours, and we can take them down there and do that. But we have to do different parameters around, do they need to wear a mask? Are they in gloves? Are they going to touch things? Kind of all the different concerns around the infection control issue to see like what we have to do. And there are some situations where we just can't make it work. During the spring and summer and fall, sometimes we can also just take them outside. So sometimes it's just putting a child in a wheelchair and being able to have a direct line outside to a specific area so they can just get some sun, and it's, and wheel around in a wheelchair and get a little vestibular, and maybe it's not enough movement. But it will give them some kind of an option. So there's a variety of things, we can do. We've been able to take some kids to a child life area in private, kind of a private situation, but they can't be with patients, and then we're cleaning after. But it just, again, it depends on the nature of the infection control issue, and we just work very intricately. So infection control is in that chart. They're looking at what they've got, they're figuring it out. We're talking about all the behavioral risk. We're talking about, how can they get there? Can they walk? Can they, whatever, will they drop? Will they, it's a huge discussion. But really, we're trying to all do what's right for the child, um, and see if we can get them out. And there are times where we can't, and then we're writing that child's social stories, and we're and coaching them on, the different things they can do, and we're trying to make sure they get out of their bed and they get in the rocking chair and they get on the floor and they get, just wherever they can, and they get in the shower, whatever it is that can be like changing their space and movement. To get them through that time, and also making sure we're communicating with them that they're not in trouble, that they're in the room because they're sick. And once we get their medicine all in or whatever cleared, then we'll start to move them out of the room.